Okay, so we'll give you the detailed explanation also. Okay, and yes, so let's begin our discussion with a clinical case. Longest question, don't be in a hurry to mark the question. What is the question? 30-year-old, 39 weeks pregnancy, completely dilated. So see, try to decipher one thing at a time. Completely dilated, that means she's 10 centimeter dilated, pushing, okay, for 3 hours, exhausted, fetal heart rate. So always look at the weeks of gestation, always look at the baby heart rate, cervix is completely dilated, effaced out, head visible at introitus, the fetal bones at station +3. Most appropriate next step in the management is what? Okay, deliver by LSCS, encourage the patient to push after a short period of rest. Forceps delivery, apply suprapubic pressure. Yes. So all these are likely kind of questions, like a longish question which you get for the upcoming NEET or FMG exams. Also, you get such kind of clinical questions, and the concept is about your. Okay, so last 10 seconds, all of you please participate. Yeah, okay, so almost 50% of you getting it correct. We'll be closing the poll in 5 seconds. All of you please participate. Yes. Okay. Now, yeah. So all these doing very well. Yes, all of you. Yes. Okay. So now what is the scenario? Can anybody tell me in the chat box what exactly are we facing? What it is? Yes. Excellent. So we have got two issues over here. One is that, of course, given clearly mother is exhausted. So maternal exhaustion is there and she has been pushing for 3 hours. So it's like a prolonged second stage, definitely. Okay. So one is the prolonged second stage which is there, and the second thing is that mother is exhausted, so maternal exhaustion. And very good, Alu Arjun, look at the baby heart rate. The baby heart rate is 100, which is definitely fetal distress, because normal heart rate, all of you know, 110 to 160. So there's fetal distress, but the other thing is that we are already fully dilated 10 centimeters and station is +3. Okay, station is the relationship between the maternal pelvis and the fetal head. Yeah. So what will you do over here? Point number one, the you don't encourage the patient to continue to push. No, after short rest, this is an emergency, there's no time. At the fetal heart rate being okay, when will this be the answer? So please understand, I'll give you all the explanations also, not only this question. So when will this be the answer? So probably if she was pushing only for half an hour or 1 hour, okay, if she was pushing only for say half an hour, 1 hour, okay, and the fetal heart rate was normal, then you can say, okay, please take some small rest and then again push. Okay, so that is not applicable over here. The reason being why this is not applicable over here, all those joining in now also, please quickly, this is the first MCQ, so pay careful attention. It's a very, very important. Okay, yes, so this is out of question because here the baby heart rate is dropping down and it's an emergency. So basically it's a fetal distress and you need to get the delivery as soon as possible. Again, suprapubic pressure is not applicable over here. Why? There's an MCQ to it, so we'll discuss it in some time later on. Which condition do you give a suprapubic pressure? Okay, and here the answer is very good, forceps delivery, because forceps is faster. Okay, so when you go for instrumental delivery or forceps delivery criteria, there's an MCQ, but the indications, maternal exhaustion, which is the case over here, and fetal distress. So both there are two indications for applying the forceps, and therefore that is the answer. And third obviously is to cut short second stage. Okay, so these are the indications for instrumental delivery, that also we discussed. Regarding certain criteria, more I'll tell you in the couple of MCQs coming in some time. And station +3 is very useful, and LSCS will take more time. Can anybody tell me why forceps is faster in this scenario? Yes, so one option, so option D is out and I have to choose between A and C, and C is the answer over here. Answer to this MCQ is forceps. Yes, LSCS also could have been done, but one of very good, Dr. Shahi. Okay, sir. One is that if I can avoid doing LSCS, why not avoid? So yes, I can avoid, and LSCS will take some time. All of you know, because forceps can happen in labor ward itself. Very good, in the labor room itself. You just quickly get the forceps blade, one blade, second blade, cut the babies out. LSCS will take time for shifting the patient to operation theater, giving anesthesia, all that. It will take some time. Yes, very good, Shisha Surya also. So all this is very, very important. Keep this in mind, that there is fetal distress, full dilatation. Very good. Yes. So let's go on to the next question and poll. Yes, again, a longish clinical question. We have got a primi gravida, 38 weeks. That's important. Gross rupture of membranes, digital examination, see the dilatation, see what is palpable, heart rate, reactive, what is it, best way to achieve the delivery. Deliver the fetus vaginally by breech extraction. Deliver baby vaginally after external cephalic version. Perform LSCS, perform internal podalic version. Yes, all those joining in now also, please stay right till the very end. And this is just a second. Lots of questions are there. We are going to have a great time. We are going to discuss images and lots of clinical MCQs also. Yes, anybody? So what is your diagnosis? Anybody, can you give me the diagnosis over here? Of course, sir, primi gravida in labor, 3 centimeters of abdomen. But yes, what it is fetal heart rate reactive means normal. Fetal heart rate reactive means normal. But the important point is fetal feet. Please, I hope you must have read this. Fetal feet palpable through the cervix. So it is a foot link breach. And can anybody tell me what is the best or the safest method to deliver foot-link breech? Is by LSCS. Why? Anybody? Because please understand this, that in foot-link breech, दो छोटे छोटे खाली पैर होते हैं. There's a very high risk of what? What is this? The baby is not passing. The baby is doing susu. No, they're not urine. Okay, there's a very high risk of cord prolapse, and it is not cord entanglement, but a cord prolapse. Okay, so it's a very, very dangerous condition because cord prolapse. So what? So if it cord prolapse, yes sir, cord prolapse would lead to the baby dying, because cord prolapse would lead to severe fetal distress. Okay, cord prolapse would lead to severe fetal distress, and then that in turn would lead to baby dying. Is this understood to all of you? So to prevent all this complication is when you would like to do a, so primi gravida with breech also, as well as footling breech also, the LSCS is the answer over here. Next, along explaining you the other options also. Internal podalic version, outdated kachra dustbin. Kachra dustbin, why? Because you used to put your hand inside the uterus and rotate the baby. Lot of lateral wall rupture uterus, almost never done in modern day obstetrics. And by the way, also not applicable over here. Internal podalic version was done for transverse lie. All of you know that. Okay. Yes, only in case of second baby of the twin you can think of doing that. Next important point, you don't do a vaginal delivery, I explained to you, because I told you the risk of fetal distress. Okay, and cord prolapse. And external cephalic version is only done when the patient is around 36 to 37 weeks. All of you know that, not when the patient is in labor and the membranes have already ruptured. Okay, so here clearly there is having good uterine contractions every 2 to 3 minutes. So she is in established labor. She is 3 centimeter dilated, membranes have ruptured. So external cephalic version cannot be done in labor. Okay, so the answer is perform an emergency LSCS. Okay, yes. Next is, yes, again a very, very important. So all these are clinical cases. I hope you will agree. Paul. Yes. Okay. Yes. So you are delivering a primi gravida patient, 41 weeks, obese. After pushing, head delivers. What happens? What is this called as? And All of the following are next steps except, okay, many of you, uh, okay, all those are joined in now. Also, Jameer, Dr. Manikandan, also please participate. The third question, okay? So, and go back and see the recordings also, what first 15 minutes you have missed. Yes, last 15 seconds, all of you please participate. Can anybody type in the chat box the diagnosis? Can anybody type the diagnosis, what has happened? 55% getting it correct. Yes, excellent. So here two things, please understand this, that obesity is a risk factor for shoulder dystocia, diabetes is a risk factor, and even postdatism. Okay, she's 41 weeks. Postdatism, the baby can become bigger in size. So remember postdatism also. Yes, and diabetes also. Okay, so here what happens is, please understand is that the baby, how do I know it is shoulder dystocia? Perfectly correct. The diagnosis is shoulder dystocia. Shoulder dystocia is a condition where the baby the head delivers, but the rest of the baby cannot deliver. Okay, I want all of you, I had also put this in the Unacademy community also a couple of days ago. So all of you, those who are there, please join the community where I keep on posting the polls, and we keep on giving one MCQ every day, and also tests are conducted. So all of you can just join my community on the Unacademy app. And yes, perfectly correct. Shesha has said is turtle sign. Okay, what is this turtle sign is that the head will retract back against the perineum, head hit back. So these words, that head delivers but retract backs against the perineum, these are the very, very crucial words in the question paper. So please read everything. And then obviously over here, this is like giving away the answer. Okay, the baby's shoulder fails to deliver. So this is to make the MCQ still easy. Yes, it's a difficult MCQ, but this is to make it slightly easier. If this line is not there also, still the answer remains the same. Okay, so basically we are having shoulder dystocia. Point number one in shoulder dystocia, and the most important point to be kept in mind is never give fundal pressure. It is very, very tempting to give fundal pressure in shoulder dystocia. Please keep a note, when you give fundal pressure, the shoulder, basically the scenario is, here is the pubic symphysis, PS I am writing, pubic symphysis, here is the baby's shoulder. Okay, so if I give fundal pressure, the shoulder will further hit the pubic symphysis and the condition is going to worsen. Yes, here is the time where you will give a suprapubic pressure, because you want the shoulder to come down and deliver. Is this understood to you, dear students? So we want this kind of a movement to happen, so we have to give a suprapubic pressure. So all of the following, of course I will immediately remove the lithotomy position, call for extra help because you might require shifting to operation theater and do the maneuvers. Point number one, sharp. Anybody, what is this option number C? Flex the maternal legs onto the abdomen, extend the episiotomy, or give the episiotomy if not already given. The answer is option number A, because it is all except. Yes, flex, sharp flexion, hip hyperflexion onto the maternal abdomen. That is almost the first maneuver we do. Please keep this in mind. So with the clap if you feel happy with one MCQ. We're discussing four MCQs. So till now we have discussed only 3 to 4 MCQs. If you see, if I just see 3 MCQs, but with almost 8-10 MCQs discussed. Yes. So this is the Mac Roberts maneuver. Okay, hip hyperflexion and abduction onto the maternal abdomen. Answer is do not give fundal pressure. That will worsen the situation. Okay, if a suprapubic, yes, very good. Yeah. Santa Claus, okay, there's a new icon. Great. Yes, last is our great. Yes. Okay. So moving on. Again, a good kind of a question, again, which tests your clinical judgment. Poll. Okay, 38 weeks, primi gravida, labor, vaginal examination, felt in the second stage. So again, second stage, matlab, I hope all of you know it is 10 centimeter dilated foot. Next line of management. LSCS forceps vacuum, rotate to mento posterior and go for vaginal delivery. Yes. So anybody, again, last 2 seconds, what is all those joining in now also? Kabilash, Pranjit, Abhishek, please quickly mark the answer. Okay, yes. Okay. Yes, very good, Sayatan and Alu Arjun. So this is, students, this is our brow presentation. Okay, brow presentation, which is one of like the least common. It's a mal presentation, brow. How do I know it is brow? Because given in the question paper that when I do. So please understand, all of you, if I am the baby and all of you look at the screen, if this is face. Okay, this is the face presentation. If the chin is completely touched to the sternum, then all of you see only the head, that is vertex. But if it's midway, okay, beach mein, okay, okay, if it is midway, that is between partial flexion and partial extension. Okay, when it is midway, okay, when it is partially flexed, okay, I repeat, completely flexed, vertex completely extended, partial जब भी होता है midway, that is giving rise to brow. I can feel the anterior fontanelle over here and the supraorbital ridges, which is clearly told to you in the question paper. Once in the difficult exam, this question has come. And brow presentation, the delivery is always by LSCS. Very good, because all of you should know that, sir, the engaging diameter in brow is mento-vertical, which is 14 centimeters, and there is no mechanism of labor for brow. Patient will keep on pushing, obstructed labor and rupture uterus. Okay, forceps and vacuum cannot be applied in brow presentation. Simple. And this to never ever. This is to completely ulta. Okay. By the way, remember why this ulta? Brow on its own. Please understand this. Here she is 10 centimeter, matlab second stage. In early labor, suppose they tell you that there is brow presentation in early labor. Suppose say she is only 1-2 centimeter. Then I can wait. Why can I wait? Because sir, brow may change. Brow may become completely flexed and become vertex. Very good. And then we can have a VD. VD, all of you know, is my short form for vaginal delivery, is possible. Brow can also become completely extended and become face. And face, again, all of you we discuss in our actual class, in the plus classes. It's a face could be mento anterior or mento posterior. Okay, so that is different. That's a separate topic altogether, face ka. But face mein again mento anterior, a vaginal delivery is possible. So you don't rotate this. You don't make brow into face. Okay, no rotation business. And mento posterior to vaginal delivery is anyway not possible. Okay, mento posterior again always requires LSCS. Okay, is this understood to all of you? Okay, so that's why that's the answer. And forceps and vacuum are contraindicated in brow. Okay, yes. So there is one more MCQ which is in relation to forceps, and then we are okay. So yes, we will go to that MCQ, but just before that, a quick simple poll, because all these are expected short questions. So yes, double marker test. When is it done? What is the test? Also called as dual marker test. Okay, dual marker test or double marker test. It consists of what? Is it HCG and alpha fetoprotein? PAPA HCG, alpha fetoprotein, UE3, inhibin PAPA. Yeah, very good. So, but Dr. Vijay and Starry, why are you late? No problem. Shraddha, okay, all of yeah, please. Yes, so very good. So, dual marker test is done in the first trimester between 11 to 13 weeks of gestation. Okay, it is a test for it's a screening test for trisomy 21. Okay, just by the way, inhibin A, only inhibin A, not PAP A. Inhibin A is a part of quadruple marker test. Is this understood to all of you? Quadruple marker में हम inhibin A करते हैं, and UE3 also is a part of your triple and quadruple. So the answer over here is HCG and PAP-A. Is this clear to all of you? Many of you might know. Okay, PAP-A. What is PAP-A? PAPPA, pregnancy associated plasma protein A. Pregnancy associated plasma protein A, and HCG and PAP-A, PAPPA. And also we should know that in case if the baby is suffering from Down syndrome or having Down syndrome, what happens to these values? Anybody? How will I know? What is the? It's a risk ratio, which will be arrow up or arrow down, arrow up or arrow. Yes. So HCG will be higher than normal, but PAP-A will be lesser than normal. So this also could be asked to you. So please understand, students, you should know by heart. I am giving you this for the short thing, that double marker test, triple marker test, quadruple marker test, and NT scan. We have to time and again, otherwise go back and see the recordings and these lectures. Please, these are extremely important MCQs. You cannot have a paper without this. Okay, so this is one of the most important and hot topics. Okay, so HCG PAPA is the answer over here. Yes, very quickly, one more MCQ, lots to discuss today. Yes, so we discussed phase, we discussed this. Yeah. Yes. So again, we have got a primary gravida, heart disease. You are planning to cut short second stage of labor by forceps. Which of the following is correct? Okay, many of you, I think, marked the question without answering. Oops, I could. Oh, very sorry. Yeah, sorry by mistake. I finished the poll early. Yeah, no problem. But those who again got it. Yes. Yeah. So please read the question correctly. It is not all except we just want to find the correct statement. Okay. Yeah. Last 5 seconds. Yes. Okay. So now please pay attention. Yeah. So all of you, this is the prerequisites for forceps. Anybody? Point number 1. Of course, the cervix should be fully dilated. I can only apply the forceps at 10 centimeter. Can anybody tell me the criteria for station? Station cannot be 0. Yes, it should be at least +2. One of the most famous MCQs expected in this year's exam, that station should be +2. Yeah, +3, +4, +5, it's outside, but +2 minimum. So at zero station means at the level of ischial spine. Okay, zero station, I cannot apply the forceps. Okay, yes. Similarly, the rotation, the head should almost be in the midline. That means we're talking about the occiput. If this is the fetal head, occiput should be in the midline at 12 o'clock or 6 o'clock or somewhere around 11 o'clock or somewhere around 10 o'clock. Okay, the rotation should be less than 45. Rotation forceps, if the occiput is somewhere over here at 9 o'clock and then you try to rotate, lot of maternal and fetal complication. So the forceps can be used. No, this is wrong. If there is more than 45-degree head rotation, you do not do this. and should not be used in caput. No, caput is there, caput is normal, you can apply it in caput, that's not a problem. Vacuum may not stick properly, there's a lot of caput, but the answer is clearly yes, I can apply it in vertex, or as I told you, mento anterior face. Mento anterior face also chalega. Forceps can be applied in vertex or mento anterior face. By the way, for vacuum, face is gone. Why? Because eyeballs will pop out. Okay, so if it is face presentation, all of you please pay attention. If this is the baby, okay, if this is the baby ka face, okay, this is the maternal pelvis. What will happen if I apply a vacuum? Can I apply a vacuum in this situation? This is mento anterior, pubic symphysis, sacral promontory. No. So vacuum absolutely contraindicated in this situation. Why? Because if I apply on a vacuum, eyeballs will pop out. Okay. Yes. So no, but Mohit, LXCS ne hoga. Yes. The yeah, okay. So Mohit, ये मेंटो anterior face है. So LSC is मेंटो anterior vaginal delivery is possible. Okay. So vaginal delivery is possible. Okay. Okay, Mohit, is it clear? Yeah, Adolf correct, baby. Okay, but vacuum absolutely contraindicated. So just by the way, keep all these points. So remember, plus 10 full dilatation याद रखेंगे, plus 2 याद रखेंगे. These are the most important. Bladder empty, bowel empty, your adequate indication, and of course LSCS backup. Okay, and operative experienced operator. All these are the important requirement. Okay. Yes, let us go on. Image based MCQ, quick one poll. Yes, so what identify the image? Relatively simple, but again a very hot topic. Non-contraceptive benefits, all except. So giving you a mix of both clinical cases. Also, we gave you labor ward emergencies. Also, we are giving you, as well as this. Yeah. Okay. So this is, what is this? This is your LNG intrauterine device. Very good. Myrina is the brand name, but we call it as LNG IUD or LNG 20. It's a levonorgestrel releasing hormonal device. This is a hormonal barrel and which releases progesterone continuously. And progesterone, all of you absolutely correct. It is going to give continuous progesterone. So I am going to give in treatment of endometrial hyperplasia. Also, it prevents, very good, it prevents endometrial cancer also. Is this understood to all of you? And the menses is going to become scanty. Okay, all of you, yesterday I have taken a YouTube session on contraception. Please go back and see that video whenever time permits, where you have discussed about myelin. I'll quickly tell you about it. That, sir, when the progesterone is continuously released in the uterine cavity, it counteracts the estrogen and prevents the lining of the uterus from growing. Yes, perfectly correct. So the lining is going to remain very, very thin, because all of you know the lining grows under the influence of estrogen. Is it understood to all of you? So lining is going to remain very, very thin, and therefore the menses become scanty. Okay, menses become scanty. Our patient may also develop amenorrhea, which is fine, not to worry. Okay, so basically it is going to help in menorrhagia also. So menorrhagia and dysmenorrhea in endometriosis also, because it is all except. And cervical mucus will become thick. All of you agree, because it is progesterone, cervical mucus will become thick. So PID episodes are lesser, and even ectopic is lesser. Okay, so it protects against ectopic is also the benefit. There is no risk not connected to breast and cervical cancer at all. It does not decrease, neither does it increase. Okay, in fact, just by the way, very little progesterone may get absorbed. So in fact, those who have breast cancer, we should preferably avoid it, but not related to cervical cancer, does not decrease the risk, does not increase the risk also. Okay, so decreased risk of cervical and breast cancer is not the benefit. Okay, endometrial cancer will decrease. Okay, it will decrease your CA endometrium, definitely. Okay, yes, is it understood to all of you? So this was the image based. Yes, now this is again what I asked in one of the recent exams, the steps of